When outcomes measurements began back in the late 80s, early 90s, there were 2 or 3 or 4 instruments. For function, there was the Oswestry Disability Index. Then later came the Neck Disability Index, which was sort of an iteration of that. The Roland Morris test for functional capacity. And then there was the SF-36, the short form 36. The RAND Corporation had developed a 200-question questionnaire asking people about their quality of life. When they began to introduce that into clinical medicine, nobody would fill it out because it was too long. So the psychometricians worked through these 200 questions and came up with a shorter form of 36 questions, and that's called the SF-36, a quality of life measure. And then there was pain. Pain's a little bit difficult because nobody really knows what somebody else's pain is, so we sort of have to take on faith that a person gives a legitimate pain indication. Typically, it's an analog scale from 0, no pain, to 10, worst pain possible. At that time, we weren't doing much clinical outcome, and as a result, we weren't using these tools very much. Over the past 20 years, probably 100 or more clinical outcome tools have been developed, most of which don't have good psychometrics behind them. They haven't been tested very well. And so it's sort of muddied the field. And when we want to try to answer those 3 questions that are so important to patients, pain, quality of life, and function, we have all of these different tools to try to get an idea of what we really want to do. Consequently, it becomes murky. And so the simpler the better. We do want to know pain, we do want to know function, we do want to know quality of life.